Hi, I'm Kristen here at UT Southwestern Medical Center. Thank you for tuning in to our Facebook Live on Acoustic Neuroma. Today we're going to be talking with otolaryngologist Walter Kutz, who's here at UT Southwestern. We are excited to thank both the Moncrief Cancer Institute as well as the Acoustic Neuroma Association for helping us promote the chat. Thank you very much for your efforts. And before we get started, don't forget to like and share the conversation. We really appreciate that, and be sure that you ask your questions in the comments field so that we see them. We will take certainly as many as we can get. So let's just go ahead and get started. Dr. Kutz, thank you for coming on and taking time to do this.
Thank you very much. It's a great opportunity to talk about acoustic neuromas and whatever else the audience may ask.
Absolutely. So I know one of the questions that comes across a lot is, is acoustic neuroma, is it a brain tumor?
Well, it's a tumor around the brain. It's not in the brain, and that is an important distinction compared to a tumor that may be in the brain, which obviously has more serious potential problems. So an acoustic neuroma actually develops around the balance nerve as the nerves come out of the brain. And they're in an area that can cause some significant problems like hearing loss, balance problems, rarely facial nerve problems. And if these get large enough, then they can cause some more significant problems where we may have spinal fluid buildup. But they're not truly a tumor in the brain.
So is it cancer?
It's not cancer.
So it's malignant. It's just a tumor.
Just benign tumor. It's not malignant. Very slow growth. If they do grow, they grow about 1 to 2 millimeters a year. So a lot of times we'll just watch these if they're small and they're fairly asymptomatic.
That sounds great. So we had a bunch of questions beforehand. So one of these, or actually a couple of them, were about tinnitus. And they ask, why can't anybody find a treatment? Now, you and I have talked, there are some treatments available, and maybe we can talk about that, and is there any research going on to find out kind of what causes it or better ways to treat it?
Yeah, that's a great question, and obviously we see a lot of patients with tinnitus is a very frustrating symptom. And tinnitus is caused generally by a high frequency or a hearing loss. And so I tell patients when I talk to them about tinnitus that it's like a phantom sensation. So you've heard of people that may have had their arm amputated. They can still feel their fingers burn. It's the same sort of phenomenon. They've had sound amputated. And so now their brain pathways are confused, and so they get this sound that's generated. It's not actually caused by the ear, but it's occurring kind of in the brain's making up the sound. So it's a phantom sensation. Because of that, it's not the most simple treatment. We don't necessarily have a medicine specifically for tinnitus, but if you can improve the sound input into the brain with hearing aids, that can oftentimes help. So seeing an otolaryngologist or an audiologist can certainly help and be something to consider. There's also masking hearing aids where a small amount of sound can be placed in the ears, and that will also decrease the level of tinnitus. And I also tell patients it's very important to control anxiety or depression, which often go along with these symptoms. So talking to the primary care doctor is a good first start to helping reduce tinnitus symptoms.
That's good to know. I know one of the persons asked about this constant music in the ears and the ringing. Is that typical?
It is. It's typical. And it could be high pitched. It could be roaring. It could be musical sounds. And the particular sound usually doesn't mean a lot, but we kind of consider it all just head noise.
That makes sense. So what about this? Are acoustic neuromas, going back to that, are they genetic?
Well, generally they're not, but there's a condition called neurofibromatosis type 2, and patients with what we'll just call NF2, it's a mouthful, patients with NF2, they do develop acoustic neuromas on both sides. And unfortunately, with time, often these patients will lose hearing on both sides. And in addition to that, they'll also develop tumors, also other tumors called meningiomas around the brain, and even the spinal cord. So that is a hereditary condition. Fortunately, that's a much less common condition than just having a single acoustic neuroma. So in general, acoustic neuromas are not hereditary except for the NF2 condition.
That's good to know. So one of the questions that came in, so Lisa, she says, I have a question. I suffer, and this is Lisa Boyd, she says, I suffer from HFS that impacts my left side, but now I suffer from tinnitus, but I have lots of vertigo this year. Could the vertigo be caused by my 7th cranial nerve be affecting my auditory nerve? If yes, is there any treatment for it?
It's a very complex problem. I certainly have to see a specialist for that and really review all the films. And so I can just generally speak on something like that. HFS sounds like it's hemifacial spasm. And what that's caused by is where the facial nerve, as it comes out of the brainstem, and the facial nerve controls our facial movement. That's irritated usually by a blood vessel. And that can cause some disfiguring facial spasm, very disturbing for patients. There are theories that the same sort of vessel could cause some dysfunction with the balance nerve, although that's not as recognized as a problem. So it's really difficult to answer that question without really going
Right.
over all the records and seeing the patient and evaluating the patient.
Okay, so good question,
Yeah, it's a
Lisa.
great question.
So
Difficult
you
problem.
definitely talk to a physician about that one. All right, let's see. We're going to try another one here from Brenda. Brenda said, I had an exacerbation of my symptoms. Then over 6 weeks, they diminished. She said, the surgeon I saw for one consult, wonder if I'd had an internal tumor bleed, but she hasn't had any further MRIs or consultations. And she's now back to the same symptoms, but with tinnitus that started then. Have you heard of something similar? Sounds really...
Yeah, I'm thinking Brenda may have an acoustic neuroma. Maybe there's bleeding into it. I'm not sure quite. I'm not sure I quite understand the question totally. But rarely you can get bleeding into an acoustic neuroma.
Okay.
You know, a lot of times you may re-image, and usually that's the only way to really know if that happened.
Okay.
So it'd be kind of difficult for me to answer. I think the question. Sorry about that.
No. So you mentioned earlier that sometimes you just want to wait and watch if you think that somebody may have acoustic neuroma. What are the symptoms that people should watch out for?
Yeah, I mean, for the typical symptoms for acoustic neuroma are going to be unilateral hearing loss or hearing loss in one ear, maybe ringing in one ear, and those are the two most common symptoms. And really with those symptoms, it's important to see an otolaryngologist who's probably going to recommend an MRI, and that's typically how these are caught. And these are very slow growing. Many patients had these for years and years, and they may say, I've had hearing loss for 5 years. I thought I might have had a cold, but never went away, or fluid in the ear. But then they get the MRI and we find the acoustic neuroma. We're actually finding many more because MRI is so more prevalent, with headaches or unexplained dizziness. And so a lot of times patients may get an MRI and find an incidental acoustic neuroma, which is not really causing symptoms. And if they're small and the hearing's good in those cases, they're not causing symptoms, typically we'd recommend watching those. Everybody may be a little different, but a lot of times we'll watch those.
Yeah, so if you have one though and you determine that watching is not the appropriate, that you're going to take it out, I mean, how likely is that person to have another acoustic neuroma? Would it come back? Is that a risk factor?
That's a great question. So a certain number of patients will undergo surgery, especially for larger acoustic neuromas or small acoustic neuromas where we may try to save hearing, because we can actually preserve hearing in some cases, very select cases. But generally with surgery, we would probably about 95% of the time remove either all of the tumor or maybe leave a very small piece of tumor behind. But these small pieces of tumor probably don't have enough blood supply to grow. So in those cases, we'll follow those maybe small residual acoustic neuromas with MRI, and we rarely have to treat those. If we do have an acoustic neuroma that grows after surgery, that small residual, we'll usually just treat it with a gamma knife radiosurgery. One-time treatment, day procedure.
Wow, a day procedure.
Day procedure, yeah. Done
that
by
sounds
noon
really
usually.
good.
That's nice.
All right, so we're going to take one of our other questions. We had a question from Tanya. She says, and this gets to vertigo, which we talked about a little bit, and maybe we could just talk about it generally. But she says, I have been diagnosed with vertigo. I have hearing loss that they said is due to nerve damage, that there's no hope. Is that still true? If so, do you have to use an outer hearing aid? And let's see, it looks like she has some other questions. What other conditions impact that? It looks like she says she has SLE.
I mean, vertigo's, it's a lot of causes for vertigo. They could be inner ear causes like positional vertigo, where you turn over in bed and you get have vertigo. That's very treatable with rehab, actually, with some vestibular therapy. You can have a virus attack your nerve, where you get what we call vestibular neuritis. So now the nerve is damaged and your brain has to learn to use only the one side. You can get Menieres disease, where you have hearing loss in one ear and increased inner ear fluid pressure. That typically causes vertigo attacks that are really pretty bad for about 2 to 4 hours at a time. And all those, the Menieres, especially in the positional vertigo, have really good treatment. The vestibular neuritis is typically treated with rehab, with rehabilitation. It's very effective. I also tell patients that they should consider something like Tai Chi. There's been good studies showing that Tai Chi 2 or 3 times a week can really help with vertigo and imbalance.
That's what I was wondering. Tai Chi, is that because of the slow motions and it helps with balance? Would yoga function the same way? Yoga
could function the same way. I think anything where we're working on balance, it's basically trying to build the balance system up to make up for that deficit of having one balance nerve not working.
Gotcha. Okay, well that actually gets to a question from Karen. Karen asked, is there any information on Menieres disease? Maybe any new treatments available for that?
There are a lot of treatments, and it's actually stepwise. So most patients, we can start with dietary modifications, low salt diet, Patients don't like doing that, especially living in Texas with Tex-Mex. But low salt diet, keeping under 1,500 milligrams a day is very important, and that's probably the best treatment.
Yeah.
And then we would move on
it's
to
hard.
it's very hard. That's the hardest prescription I give anybody is a low salt diet.
Yeah.
And then we'll move on to diuretics, and then there's some steroid injections we can do. And then rarely we'd have to do surgeries. There's actually many treatments for Menieres. I think you need to find an otolaryngologist you're comfortable with that will explore some of these treatment options. But the thing to know about Menieres disease, it is a chronic illness. Okay, so you're going to have periods where it's going to wax and wane.
Okay.
But if you get through those periods and manage the symptoms, that's the goal.
Okay. Great question, Karen. So we got another one on here. It said, are there any home remedies to tackle acoustic neuroma symptoms?
Well, I think the symptoms we're talking about, so hearing loss, you could do a hearing aid.
Right.
We talked about the tinnitus or the head noise. Hearing aid could be helpful for that. Managing anxiety. I think mindfulness is very important for symptoms such as tinnitus.
Okay.
And the dizziness, I have patients that have an acoustic neuroma. We decide to follow it, so it's still there. We haven't really treated it. They have significant vertigo and dizziness, and we'll recommend those patients to vestibular therapy, and they get much better, even without treating the acoustic neuroma. So I really think vestibular therapy is very important for the dizziness and acoustic neuroma, or really about any kind of dizziness you have that's chronic.
So when should somebody contact you or another otolaryngologist?
Yeah, I mean, I think, well, definitely you want to contact an otolaryngologist, or at least start with your primary care if you have symptoms in one ear, whether it be hearing loss, ringing in the ear. If you have dizziness that you can't explain, I think you should definitely touch base with either your primary care or an otolaryngologist at that point. And then an otolaryngologist is going to know the proper workup to kind of rule out things that are going to be more serious, like an acoustic neuroma, versus things that may have something we need to treat more of a symptom standpoint.
So what kind of, now this was one that came through earlier, what kind of treatment options are available, or what's on the horizon for acoustic neuroma?
Yeah, for the acoustic neuroma, is just the solitary you have in one ear, like most people are going to get. Really we're observing more of those. If you look over the years, we've learned that we can watch a lot of these. There's a good study out of Denmark showing that less than half of tumors that are small tumors are going to even grow over 10 years.
Wow.
And a lot of those patients will preserve their hearing over 10 years. So we've learned throughout the years that just watching these tumors, that's a very good approach.
Wow.
If they're too large, there's certain instances we wouldn't want to do that. If a tumor grows, then at that point, and the way we know that's we'll get an MRI at a certain interval. If the tumor's shown growth, at that point we do recommend treatment.
Gotcha.
That could either be with radiosurgery, which is CyberKnife or Gamma Knife. We use Gamma Knife here. It's an outpatient procedure.
Wow.
Patients come in and get a head frame placed. They get a fiducial box, so it's got little locators in the box. They get an MRI. I work with the radiation oncologist. We program the treatment for that acoustic neuroma. Treatment's about an hour to hour and a half. Patient's usually done by noon, and then maybe a little headache, a little dizziness. And then we'll follow the tumor, because a certain number of tumors may still grow. But Gamma Knife's a good treatment for a certain patient population. There are some risks to it. You have to definitely talk to your doctor about it. It's not for everybody. And then surgery, some tumors, big tumors, younger patients, we usually recommend surgical intervention. That is a little bigger procedure, probably 8-hour procedure average, and then you're in the hospital for 3 or 4 days. But it's, I think the biggest thing, I think we're learning we can follow these and not have to make a quick rash decision. We can follow these for some time. So
when you do end up doing the surgery, in terms of the impact afterwards, are you looking more at improving hearing, or are you worried more about facial nerves? Is it both?
Yeah, I mean, it really depends. If it's a small tumor with good hearing, then obviously we want to save the hearing, and you can do that a certain percent of time. It all depends on the size of the tumor and the location of the tumor, anatomically. Our number one goal, even above removing all the tumors, to have the patient come out with a good facial nerve outcome. You can't always predict that, because a facial nerve can have different. It could be affected by the tumor differently. It can lose blood supply. There's different reasons you can't have facial weakness after surgery. But that's our number one goal, and that's generally how we're going to grade our results. And like we discussed earlier, even if you leave a small bit of tumor behind, a lot of times it won't grow. So if it's really stuck to the nerve of the tumor, then we'll leave a little piece of the tumor behind and then just follow that piece.
All right, let's see. We've got a question from Sandra Church. She wants, now we talked about this a little bit earlier, and I think you said no, but is there a cure for tinnitus? Sounds like
well, there's no simple cure, but there are good treatments. And like we talked about, hearing, getting your hearing checked, wearing hearing aids. putting a fan on at night. Usually, Sandra, if you notice if you're busy and you're occupied, usually the tinnitus isn't that bad. And so what happens when you're in a quiet situation, all of a sudden your brain's focused on the tinnitus. So if you can make some background noise to help kind of drown that out, that really works well. And if it's severe and it's affecting your sleep, that's definitely a time you should see an otolaryngologist to get the hearing checked and see if there's a masking hearing aid or hearing aid.
Okay. All right. Good question, Sandra. So we've got one from Allison Feldman. Looks like Allison is with the Acoustic Neuroma Association. She says, at what age would you advise a patient to consider radiation treatment rather than radiosurgery?
Well, typically, I would. So radiation. So typically, we would treat these with radiosurgery. Okay. Radiation treatment, how I define it, is where you get multiple sets of radiation. A lot of times you'll get radiation daily for 6 weeks, and that would be for cancers like breast cancer or a lung cancer. Acoustic neuroma, we use radiosurgery, and that's a one-time treatment. Okay. There are some centers that do treatments where they may do 5 treatments. We call it hypofractionated. But in general, for acoustic neuromas, unless it's a very, very large acoustic neuroma in a very unusual setting where a patient couldn't tolerate surgery, that'd be the only time you do old-fashioned radiation therapy. So most centers are going to do radiosurgery, which is that one-time treatment. Okay.
So are there, that's a good question. Let's see. So Mary had another question. She said, what do you recommend for facial nerve concerns following AN surgery? And let's see, it looks like she may be a patient. Facial paralysis, balance, sensory issues, general fatigue, 4 months after surgery. So what do you recommend in case like that?
Yeah, if you have facial weakness after surgery, we typically recommend facial rehabilitation, and you would work with a therapist, and they're going to give you specific exercises to do to try to build those muscles. Okay, you're going to have some partial innervation, and really what we're trying to do is get those muscles stronger, and that's going to help for a quicker recovery and maybe a better recovery. Some therapists will recommend electrical stimulation. We typically don't recommend that. Okay. The reason being, we feel that if you electrically stimulate the nerve and you're really promoting growth too aggressively, the nerves may get confused where to go. And the nerve that was supposed to go to the eye may go to the lip. Right. And then you're going to get kind of mass facial movement. We call that synkinesis. So we recommend just physical therapy for facial rehabilitation. Okay, that sounds great. So we've got another question coming in. This one's from Laura. So Laura Rogers, she says, I have all the symptoms being discussed, but also have otosclerosis and just underwent a total thyroidectomy for thyroid cancer. Should I consider AN as an option? Well, if you're concerned about it, I would talk to your doctor, and an MRI will rule it out. I mean, you'll be able to diagnose an acoustic neuroma with an MRI. Okay. And so if you're concerned, I would talk to your doctor and see if they'll order an MRI. You do want to have them put the contrast, okay, to make sure you don't miss it. But if the MRI doesn't show an acoustic neuroma, then you can feel at ease. There's not going to be acoustic neuroma there. Okay. Really good question,
Laura. Hope you're able to get those answers. So let's see. So if you do end up having one of the surgeries we talked about, I mean, how much discomfort should somebody expect afterwards?
Yeah, that's a great question.
What's the recovery time?
It's not too painful of a surgery. It's basically just incisional pain. But the hard part's the vertigo, because the acoustic neuroma, although it grows in the balance nerve, there's still going to be usually some function left in that balance nerve, and you have to remove the balance nerve if you remove the tumor. So for the first couple of days, patients have a lot of vertigo, a lot of nausea. We really try to get them through that. And then by the second day, almost all patients recover. They're starting to eat normal food. But I tell patients to take 4 weeks off of work, no driving for 3 or 4 weeks, because it is going to take time for the balance to come back. Some patients will need some outpatient therapy, some won't. But the hardest part's not the pain, it's getting through the vertigo.
That sounds terrible.
Yeah, it can be challenging. But patients actually do well. I think it's important to prep patients for that. A lot of times we'll have patients see a therapist beforehand. Where we do surgery, we have a great therapy team. We're working with them, right away, the day after surgery, and every day. So, it's something we can get patients through, and it's going to give them better recovery.
Okay, that brings up a good point. You mentioned the therapy team. Who all is involved in a team when somebody has an acoustic neuroma?
It's a big team. We first of all, we have a monthly conference where we'll present patients with acoustic neuromas and other, we kind of generalize as skull-based tumors. And that conference has a neuroradiologist that's reading the films. There's 3 doctors like me, which are neurotologists of the ear, nose, and throat that treat acoustic neuroma. We have 2 neurosurgeons. We have about 3 radiation oncologists. And so there's about probably 20, 25 people.
Wow.
So we'll usually discuss cases, and then as a group we'll make some recommendations. And then if you're going to have surgery, it's going to be a surgeon like me, a neurotologist, one of our 2 neurosurgeons. Especially if we're trying to save hearing, we're going to have some special monitoring people there. We're going to monitor the facial nerve and the hearing. Anesthesiologist, we have a great nursing team that does these sort of surgeries. And then post-operative, we have great nursing, we have the physical therapists, and so it's a big team to take care of these patients.
Yeah, it sounds like it.
Yeah, so and that's important, I think, to have a good recovery and to be successful.
Sounds like it's really multidisciplinary.
It's definitely multidisciplinary.
Awesome. So we've got a question from Don. So thank you, Don. He says, I have lost 75% of my left due to my AN. So he says AN on nerve 7 and 8. What hearing options are there? Yeah, so
it's a little 75. It's hard for me to understand a percent. I think the best way to sort of figure out how much hearing you have left, can you use a telephone or not? Okay. If you can still use a telephone, you can probably still use a conventional hearing aid, and it'll work quite well. If you really can't use a telephone anymore, either because you just can't hear it or the sound is so distorted you can't understand, you're really probably not going to be able to hearing aid. I would definitely recommend discussing that with an audiologist who's really the expert at knowing about hearing aids.
Okay.
But let's say that if you can't hear out of that ear anymore and you can't wear a hearing aid, there are a couple options. One's called a cross hearing aid, where you wear a microphone hearing aid in the ear affected by the acoustic neuroma with the hearing loss. That would take the sound to a hearing aid on the other side. So at least you can hear everything from that bad ear, the side of that bad ear.
That's interesting.
There's also a bone anchored hearing aid, which is a little minor procedure. It's a little screw that gets placed behind the ear. You snap on a little device, and it'll vibrate through the bone from the bad side to the good side. So there's actually very good options. I don't think patients always know these options exist, so it's important to bring up.
Yeah, absolutely. It looks like somebody had a surgery here, and they're saying, I had this surgery in April, UT Southwestern. Thank you. We're glad.
Great.
We're glad you're here. So I know you're involved in research here at UT Southwestern. What are your areas of research that you're interested in right now?
I'm doing. We're actually looking at our gamma knife results for acoustic neuroma. We're about a quarter of the way through there, and we're planning on presenting that at one of our major meetings. About 3 years ago, we published our paper on our middle fossa results, which the middle fossa is the approach we would use to try to attempt to save hearing for small acoustic neuromas. So that was published a few years ago in the Neurosurgery Journal. I'm also do a lot of neurofibromatosis type 2 clinical research. So we treat, that's the patients that have the acoustic neuromas on both sides. And those are very challenging situations. So there's a medication called Avastin, which can be very helpful to stop these tumors from growing and sometimes preserve hearing for some time. And so we're looking very carefully at our results with Avastin. I think it's a very promising treatment for patients with the NF2 condition.
Sounds interesting. But before we go, I want to say, thank you guys so much for all of the questions so far. It's been great. We have about 7 minutes. While we're in this last period, I wanted to be sure to thank also the Moncrief Cancer Institute again, as well as the Acoustic Neuroma Association. We came to, we got another question while I was saying all that, so we're going to go back to that.
Okay.
But what we've got here is from Lisa. She says, if I wanted to consider seeing you or an associate of yours at UT Southwestern and my insurance doesn't require referrals, can we call and schedule? Do you guys require referrals, or how does that work?
That's a great question. Just if you call the main UT Southwestern line, certain conditions you can self-referral, and acoustic neuroma would be one of those conditions. If you have an acoustic neuroma and want an opinion, just please call. And there's 3 neurotologists, 2 neurosurgeons. We all work as a team, so anybody you can see, we'd be happy to see you.
Good. And I think we'll put the phone number and the online request an appointment in the comments field. So look for that, Lisa. You mentioned a minute ago, sometimes people have an acoustic neuroma on both sides. How common is that? That's
not common. I work with Dr. Laura Klesse, who's an oncologist that specializes in neurofibromatosis, and so we actually have a clinic every quarter for patients with NF2. Patients with NF2 have a lot of challenges, and so they really need that's even a bigger team approach. And so we do that clinic every quarter. And we probably are following about 50 to 60 patients with NF2 and doing the best we can to manage and keep their quality of life as high as we can.
Okay, so that that's very rare. How common is an acoustic neuroma, and what's the average age of a diagnosis?
Yeah, that's a great question. So the estimate's about 1 out of 100,000.
Okay.
It's a rare condition.
Right.
Some people say 1 out of 40,000, so somewhere in that range. Being at a center like this, we tend to, they funnel here, so it seems a lot more common to me.
Right,
But that's in reality, that's the numbers.
Okay. So the one in between like 40 and 100,000?
About that. It's
Okay.
an uncommon condition.
And what's the average age? I mean, it looked like in my research these were kind of in the 30 and up. Or is it higher than that? Lower?
They can be all ages. We've seen children.
Okay.
A lot of times the children will have NF2, but not always. We do see single tumors in children, but usually it's most common would be probably 30s to whatever
Okay.
age. It's a pretty broad age spectrum, actually.
Okay, let's
Yeah.
see. Oh, it looks like Betsy Poor would like to thank us for including Dr. Roland in the background.
These are our otolaryngology chairman right here. So
Let's see, and Don is wondering, I think he must be a patient of Dr. Isaacson's. He says, do you work with Dr. Isaacson?
I do work with Dr. Isaacson.
Yes.
I have great colleagues, I must say. We work together for 10 years now.
It's a great team environment here.
Yeah, it's great.
All right, let's see. So we had one more that I saw come through here. It was that I missed earlier. Yeah, we've got 5 minutes to go. Let's see. All right, we went back to, we didn't do this one earlier. Crystal was wondering, this gets the vertigo thing, are there signs that an episode is coming? And is there anything you can do to reduce those episodes?
Yeah, again with vertigo, you have to really, you have to try to get the best you can to get a diagnosis. Because vertigo is really a symptom, right? And so it's a terrible symptom, that's for sure. But you really want to try to get a diagnosis. If it's positional vertigo, those are crystals that are broken free in the inner ear, and that's treated by therapy.
Right.
If it's Menieres disease, it's going to be because of increased inner ear pressure, and you're going to get vertigo because of that. And then, so I think you really have to try to find an otolaryngologist that can do the best they can to identify why you're having the vertigo. And frankly, sometimes it can be somewhat difficult, but I think if you get a few opinions, hopefully you can narrow the cause down. And then some people may know it's coming, some people may not. And so it varies. Yeah.
So obviously there are, thank you by the way, Crystal, for that answer.
Yeah.
There are a lot of otolaryngologists out there. How do you find one that's a specialist in acoustic neuroma?
Yeah, I think the Acoustic Neuroma Association is a great start. It's a great organization. They actually have a list of providers. So if you're not in the Dallas area, you can look at the Acoustic Neuroma Association. I think it's a very good place to start. I think looking for a place with a team approach makes sense. Having a neurotologist, like the ear, nose, throat portion of it, working with a neurosurgeon, I think that's helpful. I think you get a little bit broader treatment options. Saying that there are very good surgeons out there that may not have a team, but I think the team approach is important. So, I think the Acoustic Neuroma Association is a good start. And then, things like this, you can maybe connect with somebody that's at a common that's had an acoustic neuroma. They can tell you about their experience and who they saw.
Okay. All right, so we've only got a couple minutes left. I just thought let's recap it. What are the symptoms that people should look for, or that people should be, that it's okay to be concerned about?
Right. Yeah, I mean, the biggest thing is if you have hearing loss in one ear, ringing in one ear, you have this dizziness you can't explain. If things are more disturbing, you're probably going to see a doctor for like facial spasm, things like that. Those are signs. If you have hearing loss that's in both ears, ringing in both ears, those are less concerning. But I do think I think you should have those looked at least once. You need to go talk to a doctor about really any kind of medical condition. But for acoustic neuroma, it's generally going to be symptoms in one ear. But saying that, we do see a lot of them that were diagnosed without any symptoms. That's what makes it a little bit challenging.
Oh, wow.
They're patient on MRI for headaches. Acoustic neuromas don't cause headaches, but they had an incidental finding of an acoustic neuroma. So they can be asymptomatic.
Okay, that's good to know. So last question, just for your sake, since we were at UT Southwestern, what do you want people to know about the program here at UT Southwestern?
Yeah, we take a lot of pride in our acoustic neuroma program, our skull-based program. We have a skull-based program here. We have a monthly conference. I think it's very valuable. We've done that for 8 or 9 years, and we just get a lot of good feedback from the group on that. We do a lot of research, clinical research. We're all very involved nationally and internationally with organizations discussing acoustic neuroma and the NF2 condition. So,
Gotcha.
I think we have a very thorough, multidisciplinary approach with a lot of experience. So we'd be more than happy to see anyone for an opinion, and just call the number, and more than happy to see anybody.
Okay, last question. Really last question. If somebody is in the community, they've had an acoustic neuroma, or they know somebody, is there anything they can do? Is there any research undergoing that they can participate in? Do we have anything going on here?
I think the for the acoustic neuromas in both ears, the NF2, we're treating a VAST, and that's pretty unique. I think for the solitary tumors, I think we were part of a multi-institutional study where we'd leave a small bit of tumor behind.
Okay.
Segmentation. So things like that. That's kind of progressive ways of treating. I think that's the best I would say. We're going to try to follow what everybody's more conservatively, and like I said, a lot of these we're just watching nowadays, and being less aggressive surgically, trying to do the best we can for a good patient outcome.
Okay. Well, I think that is all the time we had, so thank you to everybody for joining in. We have one more chat this month and we're going to be sitting down with Dr. Isaacson, Dr. Kutz's colleague here at UT Southwestern, I believe in 2 weeks, so stay tuned for that. In the meantime, thank you for joining us, and thank you for coming.
Thank you, Kristen. I enjoyed it.
Time.
Thank you very much.
Awesome.
Bye-bye.